Hi, everybody, and welcome to our module on hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a condition in which the myocardium of the left ventricle hypertrophies and grows in size, not due to a normal physiologic stimulus. In some of the other videos, I talk about how hypertrophy can occur secondary to high blood pressure or heart failure or valvular disease, but in the condition of hypertrophic cardiomyopathy, it occurs due to no obvious trigger. So you get a situation like what's shown on the screen here. On the left is a normal left ventricle. On the right is what the left ventricle might look like in someone with hypertrophic cardiomyopathy. And you can see that the walls of the left ventricle are thicker compared to normal, and the left ventricular cavity size is also smaller. Before we go any further, let me just clear up a point of confusion. Hypertrophic cardiomyopathy goes by a number of different names, and this can be confusing when you're a student. So many people call it hypertrophic cardiomyopathy or HCM, but you will also see it referred to in some sources as hypertrophic obstructive cardiomyopathy or HOCM, and there are also some older sources that will call it idiopathic hypertrophic subaortic stenosis or IHSS. These terms are all referring to the same disorder. So HCM is a genetic disorder caused by mutations in genes. About 50% of cases are familial and 50% are sporadic gene mutations. In the cases that run in families, it tends to have an autosomal dominant inheritance patterns. However, the expression of the mutated gene is variable, so there are significant variations in the severity of symptoms, and there are many variations in the location and severity of hypertrophy. So, for example, I take care of a few families with this condition. Some family members have very mild degrees of hypertrophy. Other family members have more significant degrees of hypertrophy. And it's not just the severity of the hypertrophy that can vary in HCM, it's also the location of the hypertrophy that can vary from case to case. Shown on the screen are a couple of the many patterns of HCM that you can see. So, for example, in the subaortic pattern shown at the top left of the screen, this portion of the left ventricular wall, this is the septum between the LV here and the right ventricle over here, and this portion of the septum just below the aortic valve is thickened. There are also many other variants, including the midventricular, the apical, the diffuse, and others not shown on this slide. The gene mutations that lead to HCM are often single-point missense mutations, and I discussed this type of mutation in greater detail in the videos on DNA mutations in the cell biology section. But by way of review, a point mutation is when a nucleotide substitution leads to an altered amino acid in the final protein. And there are 15 or more genes with 1,500 plus mutations that have been identified in patients with HCM. Many of these mutations involve genes that code for cardiac sarcomere proteins. So, for example, about 40% of cases involve genes that code for beta-myosin heavy chain. About another 40% involve genes that code for myosin binding proteins. The classic histology finding on the biopsy of a patient with HCM is myocyte disarray and excessive branching of myocytes. At the bottom right side of the screen is a picture of normal myocardial tissue. You can see that the lines are relatively straight in this tissue and it's relatively organized. On the left is an example from a patient with HCM, and it's very easy to see that the tissue is swirly and less organized compared to normal. You can also, of course, see hypertrophy of myocytes, and sometimes you can also see interstitial fibrosis. Now that we understand the genetics and the histology of HCM, let's talk about the clinical features. First of all, you should be aware that many patients are asymptomatic, especially when one of the genes for HCM is identified in a family and family members are screened. You often uncover many family members with HCM who were unaware they had the disorder. When symptoms do develop, they can include heart failure. The thickened myocardium can fail to relax normally, and this can lead to diastolic dysfunction like I talk about in the heart failure videos. In addition, the left ventricle of patients with HCM can have difficulty emptying due to left ventricular outflow tract obstruction. And we'll talk more about LVOT obstruction in a minute because it's responsible for a number of the clinical features of HCM. Patients with this disorder can also develop chest pain or angina. There are a number of mechanisms for this, but one of them that is important for you to know for step one is that the hypertrophied myocardium has increased oxygen demand, and this is a setup for an imbalance in O2 supply and demand. One of the feared outcomes of HCM is sudden cardiac death. The abnormal myocytes can lead to ventricular arrhythmias, including ventricular fibrillation and cardiac arrest. And in fact, HCM is the most common cause of sudden cardiac death in young patients. Remember what I told you before, many patients with this disorder are unaware that they have it, and therefore a ventricular arrhythmia can be the first sign of the disease. Syncope can also occur in HCM. First of all, arrhythmias can lead to syncope. But in addition, the thickened myocardium can obstruct the outflow of the left ventricle. This is called LVOT obstruction. I mentioned this on the last slide, and we'll talk more about this in a minute. And then finally, mitral regurgitation can potentially develop because the way the blood flows out of the heart in some cases of HCM can damage the mitral valve, and we'll also talk about that in a minute. So the way to remember all the clinical features of HCM is to think about these patients as having three basic problems. And the first problem is an arrhythmia problem. As I mentioned before, the thick myocardium is vulnerable to arrhythmias, and the most serious is ventricular tachycardia, which can lead to sudden death. It's important for you to remember that exercise and the catecholamines that go along with exercise increase the risk of these arrhythmias and sudden cardiac death. And for that reason, HCM is a common cause of sudden death in athletes. Many young patients are unaware they have this disorder, and then they exercise. That triggers a ventricular arrhythmia, and that's how they die. Because of the risk of serious arrhythmias, defibrillators are implanted in patients who are at high risk. And in addition, we tell patients with HCM that they need to avoid exercise, and this can be a big problem if a young competitive athlete is diagnosed with this disorder. The second problem in HCM is an outflow obstruction problem. This occurs in certain variants of hypertrophic cardiomyopathy where the outflow of the left ventricle is obstructed by thick myocardium. If you look at this picture at the bottom right side of the screen, I want you to imagine blood trying to leave the left ventricle and go through the aortic valve into the aorta. Now imagine that this myocardium is very thick here right below the aortic valve. I want you to further imagine that as the ventricle contracts, this myocardium below the aortic valve gets even thicker. You can imagine how this would obstruct flow out of the left ventricle, and this is called LVOT obstruction, or left ventricular outflow tract obstruction, and this is responsible for many of the signs and symptoms of HCM. This has the same physics and symptoms as aortic stenosis. In aortic stenosis, the aortic valve is thick and it blocks blood leaving the left ventricle. In this case, we have a thickened myocardium also blocking blood as it leaves the left ventricle. This can lead to heart failure because blood can't get out of the left ventricle. It can lead to chest pain because the left ventricular end diastolic pressure can rise, and that diminishes coronary blood flow. And this can also cause exercise-induced syncope. When patients exercise, the myocardium contracts even more vigorously, and that obstruction gets greater, and this can lead to such an obstruction to flow that the patient can faint. This is sometimes treated with surgery. It's called a myomectomy, where some of the septum is removed to relieve the obstruction. It can also be treated with beta blockers and calcium channel blockers. Beta blockers decrease contractility, and so do certain calcium channel blockers like verapamil. And if you decrease the contractility, you decrease the amount of thickening that will occur in that septum below the aortic valve, and that lessens the obstruction to blood flow. And then the third problem in HCM is a mitral valve problem. If we look at this picture again at the bottom right side of the screen here, as blood flows out of the left ventricle and into the aorta, in patients who have LVOT obstruction, that blood flow takes on a very high velocity as it squeezes through the narrow LVOT. This will tug on the anterior leaflet of the mitral valve, and it can even pull the anterior leaflet forward. This is called systolic anterior motion of the mitral valve. It's called systolic because it occurs in systole. And over time, this can damage the mitral valve, and therefore patients with HCM often develop mitral regurgitation. All right, for the next few slides, I'm going to talk about the murmur of HCM because this is a high-yield topic for step one. So patients with HCM who have outflow tract obstruction will have a systolic ejection murmur. I talk about systolic ejection murmurs and give some examples of them in the video on heart murmurs, but by way of review, these murmurs occur between S1 and S2. That's when systole occurs, and they are described as crescendo-decrescendo, meaning they get louder and then quieter during systole. And the murmur of HCM sounds just like the murmur of aortic stenosis unless you do physical exam maneuvers, which we'll talk about in the next few slides. These maneuvers can differentiate aortic stenosis from HCM. And in addition to the systolic ejection murmur, there are many other associated abnormal heart sounds that can potentially be heard. You can hear an S4. This is a heart sound associated with a thickened, stiff myocardium. You can hear the murmur of mitral regurgitation, and you can also hear a paradoxical split S2. A lot of students memorize the different physical exam maneuvers and the effects they have on the murmur of HCM, but a much easier way to remember the effects of the maneuvers is to just think about the size of the left ventricle. Any maneuver that increases the size of the left ventricle will make the murmur of HCM quieter. Any maneuver that decreases the size of the left ventricle will make the murmur of HCM louder. The reason for this is because if you look at this picture on the bottom right side of the screen, anytime the LV cavity shrinks, it pulls this thickened myocardium further into the LVOT. That obstructs flow to a greater degree and makes the murmur louder. Anything that makes the left ventricular chamber bigger will push this myocardium out of the way and allow blood to flow more easily, and that will diminish the murmur. So with those principles in mind, let's talk about specific maneuvers you can perform on physical exam to determine their effects on the murmur of HCM. The first one is the Valsalva maneuver. There are a couple of ways to do this. The way I was taught to do it was to ask the patient to bear down as if they're having a bowel movement. You can also ask the patient to blow out against a closed glottis. But by whatever technique you use, this will increase the thoracic pressure, which will compress veins in the chest, and this will decrease the venous return to the heart. When there's less venous return to the heart, there's less preload, and the left ventricular cavity shrinks in size. And this is the thing you want to remember about the Valsalva maneuver. This will cause, as we discussed in the last slide, the obstructing septum to move further into the outflow tract, and therefore the murmur will increase in intensity when the patient performs the Valsalva maneuver. When you ask patients to squat, this has effects opposite to those of the Valsalva maneuver. Squatting forces blood volume stored in the legs to go back to the heart. This increases the venous return and the preload. This will increase the size of the left ventricular cavity. Therefore, there will be less obstruction to flow. Therefore, the murmur will decrease in intensity. If you ask the patient to lie on the table and you raise the legs over the head, this will increase venous return. Basically, it pours blood back towards the heart. More venous return means more preload, which means a bigger left ventricular cavity. As we have discussed, this moves the obstructing septum out of the way, and therefore the murmur decreases in intensity. If you ask the patient to go from a lying position to a standing position, this has the opposite mechanism of leg raise. It will pull blood away from the heart, shrink the cavity, and therefore the murmur will increase in intensity. In the modern era, it's very easy to differentiate aortic stenosis from HCM simply by doing an imaging test of the heart like an echocardiogram. But years ago, it was very difficult to differentiate these two disorders. And in fact, sometimes patients went to the operating room for aortic stenosis, and when the chest was opened, it was determined that they had HCM. So in that era, differentiating aortic stenosis from HCM was very important, and the way it was done was with the maneuvers I described on the last two slides. So the reason these two disorders can mimic one another is because both HCM and AS causes systolic ejection murmur. Now, in general, there is less effect of maneuvers on aortic stenosis. Aortic stenosis is a fixed obstruction, whereas HCM is a dynamic obstruction, meaning that as the ventricle contracts, the obstruction gets worse because the myocardium thickens and causes more obstruction to blood flow. In addition, the maneuvers I described on the last few slides have the opposite effects in aortic stenosis. When there is less preload to the left ventricle, there is less flow across the aortic valve and therefore a quieter AS murmur. Therefore, anything that decreases preload will decrease the intensity of AS. And as we discussed, things that decrease the preload make the murmur of HCM louder. So if you wish to memorize these maneuvers, here's a summary slide. Valsalva and standing both increase the intensity of the HCM murmur. Squatting and leg raise both decrease the intensity. There are a couple of clinical situations that are associated with HCM that you should be aware of. The first one is maternal diabetes. When mothers have diabetes, their infants often have transient hypertrophic cardiomyopathy after birth. This is usually a thickening of the interventricular septum between the LV and the RV, and the baby can have a small LV chamber, and this can lead to obstruction in the newborn. This usually resolves by a few months of age. And the easy way to remember this is to just think that when the mother has diabetes, it delivers lots of sugar and fuel to the heart, and therefore the heart can become a little bit extra thick at the time of birth. Another associated condition is Friedreich ataxia. This is a rare autosomal recessive CNS disease. It is a trinucleotide repeat disorder, and I discussed this in more detail in the genetics section in the video on trinucleotide repeat disorders. Patients with this disorder have spinocerebellar symptoms, including muscle weakness and loss of balance. That's why it's called Friedreich ataxia. They also often have concentric left ventricular hypertrophy and septal hypertrophy, and they can potentially develop outflow tract obstruction like patients with HOCM have. At the beginning of this video, I mentioned that hypertrophic cardiomyopathy occurs when myocytes undergo hypertrophy without an obvious stimuli. What I want to mention on this slide is some of the common stimuli that you'll see in clinical practice that lead to cardiac hypertrophy outside of cases of HCM. The first one is hypertension. Hypertension increases the afterload on the left ventricle, and it causes myocytes to undergo hypertrophy. It leads to a form of hypertrophy of the left ventricle called concentric hypertrophy. So let's imagine that this is the left ventricle here we're looking at in cross-section. In concentric hypertrophy, what happens is the cavity does not increase in size, but the walls thicken, and therefore you get very thick walls, but a cavity that is not dilated. This is called concentric hypertrophy. There is another form of hypertrophy called eccentric hypertrophy. In eccentric hypertrophy, the walls do not thicken, but the cavity dilates. In other words, you have these very elongated but thin walls of the left ventricle. This is called eccentric hypertrophy, and this occurs in patients who have myocardial infarction and certain forms of valvular disease. But concentric hypertrophy is the type of hypertrophy seen in hypertension. Patients with valve disease can develop either concentric hypertrophy or eccentric hypertrophy depending on the type of valve disease. Valve diseases like aortic stenosis that raise the afterload cause concentric hypertrophy, just like hypertension. Other valve diseases like aortic regurgitation tend to cause the heart to become congested, and that leads to volume overload and eccentric hypertrophy. And then finally, athletes often develop cardiac hypertrophy as a physiologic adaptation to exercise. Endurance athletes like marathon runners develop eccentric hypertrophy, and their cavities can get very large and dilated from that long distance running. Strength training like weightlifting leads to concentric hypertrophy, similar to the effects of hypertension. The walls of the left ventricle will get very thick. Most athletes do a combination of endurance and strength training. So in most athletes, if you do an echocardiogram of the heart, what you often see is an increase in the left ventricular cavity size. That's that eccentric hypertrophy. You also see an increase in the wall thickness. That's that concentric hypertrophy. And in addition, the left ventricular ejection fraction should always be normal or increased in athletes. Now, in addition to those causes on the last slide, there are a couple of rare pathologic causes of cardiac hypertrophy that you should know for the Step 1 exam. The first one is Fabry disease. This is a lysosomal storage disease, and I talk about it in greater detail in the biochemistry section. It's caused by a deficiency of the enzyme alpha-galactosidase A. Children born with this condition will have neuropathy, they have skin lesions, they don't sweat normally, and in addition, they can have left ventricular hypertrophy because they are missing a lysosomal enzyme. And then finally, Pompe disease is a glycogen storage disease. I also talk about this in the biochemistry section. It is caused by a deficiency of the enzyme acid alpha-glucosidase. Children with this condition have enlarged muscles and hypotonia, and they can also develop cardiac enlargement and hypertrophy. And that concludes our video on hypertrophic cardiomyopathy.